Good morning, good afternoon, good evening, wherever you are. This is a webinar, the first webinar we will have between OrthoTV and ONLAT, the Ibero-Latinamerican Federation of Shockwaves and Tissue Engineering. This is the first. We will have a total of 5 during this year, where we will discuss the different topics related to the role of shockwaves in the treatment of musculoskeletal pathology with the most important experts all over the world. I am very happy to introduce Dr. Leonardo Guiloff. He is one of the pioneers of these techniques. He is well known all over the world. He is from Chile, Santiago de Chile, and he is a former president of our federation and a very active researcher and clinician using this kind of techniques. Leonardo, it's a pleasure to have you here.
Thank you very much, Daniel. Good morning to people from America. Good evening to people from India. Good afternoon for people to Europe. For me, it's a great honor to be here, sharing with a very good group of experts of America, with you people from Europe and from Asia, our technique that is something that I am using since 22 years from now. I think that is a very important thing to share our knowledge with everybody of you. And first of all, this first course that we are going to do is we are going to tell you the basic principles of one of the regenerative medicine technique that is shockwave. To do this, that is a physic wave using in the tissues. I will introduce first our very expert physics, Dr. Achim Loske, that is PhD in physics, that has published a lot of papers and books in physics, that have the only lab in all America that is dedicated in the University UNAM of Mexico only to study the shockwaves. And I would like to ask Ashim if he would be the possibility to tell us, to all Asian America, what is a shockwave, Ashim? Why we have to use shockwaves? Please, Ashim, tell us.
Thank you very much. I thank you. I thank the organizers, and I'm pleased to be one of the speakers. I will try to share my screen with you now. I hope everybody can see it.
Absolutely.
Okay. Well, I will talk a little about the physics of shock waves and radial pressure waves, cavitation, and some recommendations from a physics point of view. Unfortunately, I will have to skip topics 4 and 5, but it is easy to obtain good information from the companies and on how these devices work. So let's start with one important question. What is a shock wave? In nature, there are 2 types of shock waves, electromagnetic and mechanical shock waves, and electromagnetic and mechanical waves, and shock waves, as well as radial pressure waves, belong to mechanical waves. They need a medium to propagate. And it is important to have in mind that they transport energy, not matter. They move matter, but they transport energy. On the other side, electromagnetic waves do not need a medium to propagate. Examples are light, laser, radio, microwaves, X-rays. And a shock wave is a high compression peak. It is a very, very short pressure peak with a duration of about between 1 and 3 microseconds, a compression of up to 150 MPa, which is a lot, more or less 1,500 atmospheres. And it has also a negative or rarefaction phase, which goes down to minus 30 MPa. So keep in mind that this is a very fast rising peak. For clinical application, it is important to remember that radial pressure waves have a much slower rise time, more or less 3 microseconds, and also lower compression amplitude up to 5.5 megapascals, negative or rarefaction phase. The negative pressure goes down to more or less minus 66.5 megapascal. And one thing is the pressure on the air compressor. If you use a pneumatic device, of a pneumatic radial pressure device, it is normally given in bar. And another very different thing is the amplitude of the pressure field emitted by this device. So this is one of the important concepts. This is a nice comparison slide where you can see the difference between a shock wave and a radial pressure wave. Some effects may be similar, but the pressure profiles are very different. So we cannot use one or the other device as they would have the same or similar pressure profiles. I recommend to talk a little bit about some important concepts: pressure, frequency, energy density, and focal size or focal zones. As you may remember from your physics school's lessons, pressure is the force per unit area. It is given in newtons per square meter. The pressure of radial waves is normally given in megapascal, and the air pressure, as I already said, is given of the device is given in bars, but it is the air pressure that is making this device to work. Maybe you remember that 1 megapascal is 1 Newton per square meter. 1 bar is more or less 1 atmosphere, and 1 megapascal equals to 10 bars. In our context, the frequency may have 2 meanings. For one meaning is the cycles per second. This is the frequency of the wave by itself. And the other one is the rate at which, this is a nice picture where you can see a collapsing bubble and microjet emission. Always remember that the pressure and the energy density are different concepts. There is no conversion between bars and millijoules per per square millimeters. This is sometimes a confusion. A correlation may be found between these two values, but it will depend on the equipment you are using. If you do not mention exactly what equipment, what model you are using, there is no sense in doing a conversion between bars and millijoules per square millimeters. And I'm referring to the pressure on the air pressure on the device mentioned in bars. There's no unique parameter to measure efficiency. So far, we don't know, and maybe there is no unique parameter to measure what we could call efficiency. And maybe we have to ask first, what do we mean? What do we mean by efficiency? Depending on the case, focused shock waves or radial pressure waves may be more or less effective. Both shock waves and radial pressure waves may produce tissue damage. This is important, especially if you have air cavities inside the body. Both devices can be very, very dangerous. So you have to be very careful on what procedure you are performing, you're doing. Another important issue is that if there is an air gap, if there are air bubbles between the membrane and the applicator, the shock waves, the energy won't get in. The air is like a wall to the passage of a mechanical wave. So be very careful not to have bubbles or air layers between the skin of the patient and your device. Be aware of the angle of the skin and the applicator. This is important for the outcoming of the treatment. And do not use radial pressure waves to treat deep zones, because the energy density from that radial pressure wave devices generate have low energy density, a few centimeters inside the body. So do not use these devices to treat deep zones. And well, thank you very much for your attention. I hope this will maybe not answer a lot of your questions, but I hope that you have a lot of questions now. And this topic regarding to physics is very, very huge, but there are a lot of books and information that you can read, and I hope this is not the only course that you are going to take in regard to physics, but I hope you have many questions now that you can ask, and keep on. Please always stay informed. This is very important. So if you have questions, be free to contact me by email. And thank you very much for this opportunity.
Thank you very much. Thank you very much, Professor Loske. If the questions for everybody, please, we are going to accept it only by chat. The questions are going to be made at the end of all the presentations. So you have to be patient. And now and afterwards, I want to read these questions. In second place, we are going to ask to Dr. Schuh. Dr. Schuh is bioengineering, PhD bioengineering, working now in Chile. She is PhD from Technical Science of University of Technology in Vienna. Now she is the Director of Science and Innovation in Medicine in a Chilean university. And she is an expert in the biology of shockwaves. I will please ask Dr. Schuh to explain us how the shockwaves that Achim explained us in the physics is biologically explaining too. Please, Dr. Schuh.
Thank you, Leonardo. I have to say, I'm the sub-director, I'm not the director. I'm not that important yet.
You're very important.
Thank you very much for the nice. Thank you very much for the nice introduction. One second. I'm going to talk today about the biological mechanisms of action behind shockwave treatment. So you've probably Googled a bit before extracorporeal shockwave treatment and what are the effects, what can we see, what is it used for in the clinics. And one thing you probably noticed was that extracorporeal shockwave treatment displays effects in many tissues. Yeah? So we have beneficial effects of the extracorporeal shockwave treatment in bone regeneration, in wound healing, in tendinopathies, in calcification of the shoulder, in periodontal disease, nerve regeneration, and many more. And usually, as you know, those tissues usually do not respond to the same treatment. So why is it that shockwave treatment displays all these positive effects on so many different tissues? And the answer to this is it's not one effect, but it's an interplay of beneficial effects of the shockwave on the tissues. Among those effects are angiogenesis. We have an anti-inflammatory effect. We have effects on nitric oxide, macrophage differentiation, and many more. And today I'm going to talk a bit about how these effects come into place. As a first effect, and probably the most well-known effect of extracorporeal shockwave treatment is angiogenesis. Angiogenesis is the formation of new blood vessels from already existing blood vessels. So as we all know, in injured tissue and in diseased tissue, we usually have a problem with vascularization. And extracorporeal shockwave treatment is able to trigger endothelial cells to produce more vascular endothelial growth factor. And with that, we have an increased vessel formation, we have increased tissue perfusion, and we have increased tissue regeneration. But that is only one of the effects. Another very interesting effect is the modulation of endogenous nitric oxide synthase. With an increase of endogenous nitric oxide synthase, we have increased nitric oxide levels, which again leads to the suppression of the activation of NF-kappa B, which is associated to inflammation. So increasing the nitric oxide levels decreases inflammation. Another effect that we can observe here is also a vasodilative effect, which again increases perfusion of the treated tissue. So extracorporeal shockwave treatment increases endogenous nitric oxide synthase, increases nitric oxide levels, with that suppression of NF-kappa B and decrease of inflammation. To stay in the field of immunomodulation, another very interesting effect is the modulation of macrophages. So as we know, macrophages have two phenotypes. And we have the M1 phenotype and the M2 phenotype. And they're both very different. Even though they're both macrophages, they're very different fields of action. The M1 phenotype of macrophages is activated by LPS, TNF-alpha, and interferon gamma, pro-inflammatory cytokines. And with the activation, we have, again, a secretion of pro-inflammatory cytokines with TNF-alpha, interleukin beta. And with that, we have the M1 phenotype, which is primarily involved in the bactericidal activity, stimulation of inflammation, and stimulation of the immune system. On the other hand, we have the M2 phenotype. The M2 phenotype is triggered by interleukin 4, interleukin 13, interleukin 10, TGF-beta, anti-inflammatory cytokines. The M2 phenotype is associated to tissue repair, matrix remodeling, angiogenesis, and immunosuppression. And again, it secretes anti-inflammatory cytokines. So how does extracorporeal shockwave treatment affect the differentiation of macrophages? In the year 2015, in an experimental setup, Sukubo et al. Had a look at how extracorporeal shockwave treatment affects the differentiation of macrophages. So they subjected macrophages that are undifferentiated, neither M1 nor M2, to extracorporeal shockwave treatment, and we're evaluating whether extracorporeal shockwave treatment alone can trigger this differentiation. And they found that extracorporeal shockwave treatment alone does not trigger a differentiation. However, what extracorporeal shockwave treatment does is it decreases the effect of LPS, TNF-alpha, and interferon gamma on the differentiation of the M1 phenotype, meaning that we have a decrease of the M1 phenotype. And if you give the macrophages anti-inflammatory cytokines, it increases this effect. So that those macrophages stimulated with interleukin 4, for example, and treated with extracorporeal shockwave treatment produce more anti-inflammatory cytokines. Another important effect is extracellular ATP. So cells and tissues treated with shockwave treatment secrete more ATP. This extracellular ATP can bind to P2Y receptors, activate several pathways, which again leads to cell proliferation, increased cell survival, and that is beneficial in fields like wound healing, for example. A usually very interesting field in general in tissue regeneration are mesenchymal stem cells. Mesenchymal stem cells adult mesenchymal stem cells are present in many tissues, including the synovial fluid, hair follicles, bone marrow, dental pulp, adipose tissue, and the umbilical cord, among many others. And these tissue-resident mesenchymal stem cells are crucially involved in tissue regeneration. However, one of the issues with those tissue-resident stem cells is that with age, they decrease in number and in quality. So meaning that they are not capable of fulfilling their functions. What are their functions? On the one hand, we have differentiation into tissues. And on the other hand, we have the secretion of cytokines, of growth factors, etc. So with age, we see that the quality and the number of the stem cells decreases. And with that, extracorporeal shockwave treatment has been interesting in showing effects. What are the effects of extracorporeal shockwave treatment on mesenchymal stem cells? It has been found that extracorporeal shockwave treatment attracts mesenchymal stem cells to injured tissue, meaning that they migrate exactly to the site of injury. It has also been shown that extracorporeal shockwave treatment improves the quality of mesenchymal stem cells, meaning that mesenchymal stem cells that have aged, that are not capable of differentiating into tissues, into different cell types, they're not secreting growth factors anymore. Stimulated with shockwave, they're capable of differentiating again. And the third effect that was found was that extracorporeal shockwave treatment modulates the cytokine release. So with extracorporeal shockwave treatment, in those cells, we have less pro-inflammatory cytokines and more anti-inflammatory cytokine release. And if you look at those factors, we've heard those a couple minutes ago. TNF-alpha is responsible for macrophage differentiation and interleukin-beta as well, but for the M2 macrophage. So we have an increase of cytokines that trigger M2 macrophage differentiation and a decrease of cytokines that trigger M1 differentiation. What we also found was that an important characteristic of cells is the ability to migrate towards a stimulus. It has been shown that extracorporeal shockwave treatment can stimulate that cells migrate faster and more directed to a certain stimulus. The stimulus can be cytokines, the stimulus can be the shockwave itself, the stimulus can be an injury. So looking at all these effects, what is the underlying concept of all those effects? It's called mechanotransduction, which means that cells can detect a mechanical stimulus and convert this mechanical stimulus into a biochemical signal. This can also lead to effects in fundamental functions. Fundamental functions of cells are cellular migration, proliferation, differentiation, and apoptosis. And I'm not going to go into detail here, just to show you that there's a multitude of things that can be triggered by mechanotransduction. And one thing you've heard today before, and that is a G protein coupled receptor, increasing nitric oxide synthase, increasing nitric oxide, which again leads to activation of nuclear transcription factors and a cellular response. So summarizing, extracorporeal shockwave treatment in tissue regeneration displays effects due to an interplay of many beneficial effects. These effects include angiogenesis, immunomodulation, anti-inflammatory effects, and effects on stem cells. The underlying concept of these beneficial effects is mechanotransduction. Thank you very much for your attention. And if you have any questions, please let us know in the chat.
Thank you very much, Dr. Schuh. This was a very, very important conference to us. Everybody that also that we are doing every day shockwaves, we learn every day more and more from you. Thank you very much. Now, I have a great question for the most important pioneers in teaching shockwaves I think, in America, in Ibero-America, and now in Asia. It is our president, but have the honor to present him to teach us the indications of these shockwaves. Professor Moya is our president, was past president from the World Association, yes, SMST of Shockwaves, is a professor of the university, the Catholic University in Buenos Aires, and as an expert, is an orthopedic surgeon expert in shoulder and elbow. So for me, it's an honor to ask you, Professor Moya, how we can use in clinica these shockwaves that Christina and Achim has tell us. Please, Professor Moya, we would like too much to hear you now.
Thank you very much, Leo. You are a good friend. I will try to give a general idea about the different indications. As we have seen, the physics and biology of shockwaves are really amazing, and the results that we get treating patients with this energy are similar. In fact, the shockwaves are very peculiar because we see today that there are different regenerative methods that have proven very good results in the laboratory, but they are still controversial in the clinical application. Shockwaves are just the opposite. They began to show in clinics amazing results that later were described its intrinsic mechanism by researchers like Christina, Schuh, and Achim Loske. So we have clear that from the physical point of view, we have two technologies: focused shockwaves and radial pressure waves. And this is a consensus about the correct nomenclature of this technology that was done by the managing board of the International Society for Medical Shockwave Treatment in Naples in 2016. Since that time, the definitions have not changed. So the correct way to speak about these both technologies is focused shockwaves and radial pressure waves. There is also a consensus about the incumbency of these technologies. Focus waves should be applied by trained physicians, and radial pressure waves can be applied by physicians, by physiotherapists, by nurses, according to the law of each country. Why about this difference? Because the level of risk of the focus waves is different than the level of risk of the radial pressure waves. And the type of pathology that we treat with focus waves, specifically with focus waves, like non-unions or calcifications, implies the need of X-rays, different studies, decisions like making a plaster or going to surgery. So the field is completely different comparing to a tendinopathy. This was also approved in 2016 in Naples, and are the approved standard indications. There are different qualities of indications, but the approved standard indications are those indications in which there is no discussion about the scientific support to use the shock waves and radial pressure waves in these conditions. And we include chronic tendinopathies like calcifying tendinopathies of the shoulder, lateral epicondylopathy of the elbow, greater trochanter pace syndrome, patellar and Achilles tendinopathy, and plantar fasciitis. And then we have bone pathologies, delayed bone union, non-unions, stress fractures, avascular bone necrosis, osteochondritis of dissecans, and finally skin pathologies like delayed or non-healing bones, skin ulcers, and non-circumferential burn wounds. There are other indications that have different level of scientific evidence. Some of them are of frequent use, like for instance, the medial epicondylopathy, but others are experimental and should be used, those experimental indications, just by experts and preferably in hospitals, in institutions that have a good support if there is some complication. So we speak about radial pressure waves and focus waves. And as Dr. Loske said, there are different types of physical features and also the way of action, the way they act. Unfortunately, there is a lot of confusion in the literature and in the commercial area when these kind of devices are sold, and it is not completely clear. But we use the ISMT consensus. There are some pathologies in which we can choose between radial or focus waves because we know we will have a good response with the treatment. For instance, most of the tendinopathies, plantar fasciitis, and greater trochanter pain syndrome. But in other cases, we need a higher level of energy, a deeper area of treatment, and in those cases of calcific tendinopathies and bone indications, we prefer focus, and we advise the use of focus shockwaves. Finally, there are some indications in which we prefer radial pressure waves, like trigger points, especially if they are located in places where we could affect the lung or arteries. They have been described complications as, for instance, aneurysms of the vertebral artery for treating the trigger points in the neck with focus waves. So we prefer radial pressure waves in those cases. And spasticity. There are very good results with the use of radial pressure waves in spasticity. This is a study that we published 3 years ago in the Journal of Bone and Joint Surgery using the grade of recommendation system that the journal has developed. And we have different levels of recommendation according to the quality of scientific evidence. For instance, we have a grade of recommendation A for calcific tendinopathy of the shoulder when we use focus waves, because the quality of the scientific evidence is very high. The same for plantar fasciitis. These, the use both of focus and radial waves have been not only approved, but also advised, for instance, by the College of Foot and Ankle Surgeons in the US. There are a level of recommendation B for lateral epicondylopathy, greater trochanter pain syndrome, patellar and Achilles tendinopathy, and in those cases, both with radial and focus waves. For instance, in greater trochanter pain syndrome, there is more evidence with radial waves, but we are receiving information, and in our case, we have personal experience of good results with focus waves. Then we have also a grade of recommendation B for the use of focus waves for non-unions. And we have a grade of recommendation I that means inconsistent because there is not enough information for the treatment of calcifications of the rotator cuff with radial pressure waves. The quality of the papers and the amount of the papers is not enough. To finish, in non-calcific tendinopathies of the shoulder, both focus and radial waves have controversial results in the literature. So we cannot recommend in favor or against the use of these, because the quality of the studies is not good. Even those who are in favor or those who are against the use of waves in this condition are papers of bad quality, in which the most of them, not all, but the criteria for inclusion, exclusion, the way they made the diagnosis is not clear. So, and we see these kind of problems where people use waves, but they do not have a deep understanding of the pathology they are treating. Having a shockwave device does not make us expert in a specific pathology. Here we can see a very interesting example of the result using focus waves in calcifications of the rotator cuff. This is a Gerner 1 calcification, a very young calcification that will not disappear spontaneously. And after one session, that's not common, but in this case, in this woman, after one session of shock waves, the calcification disappeared. So we need to consider this instead of surgery when treating these conditions. We must say as well that in this case we got a complication that was not an important complication, but the patient developed pain, sharp pain after the treatment, because she had an acute resorption of the calcification. So we need to have the ability to treat these cases if there is a complication. This is another case. The patient that I have just shown you was treated with electrohydraulic focus waves. This patient was treated by piezoelectric shock waves. And you see this patient had sharp pain, calcification of the subscapularis. This is the three-dimensional CT, where you can see the calcification. It looks like having the same consistency of the coracoid process. And after the 3 sessions with a piezoelectric device, the calcification disappeared, and also the symptoms. We have shown with Silvia Ramon and the group of Hospital Quirón in Barcelona that when we decide to treat these patients with shockwaves instead of surgery, we got savings that are between 6 to 7 times in favor of shockwaves comparing to arthroscopic surgery. So it is worth to treat these patients. Generally, the worst result we can get is that there are not changes, because we get good results in around 75% of the cases, but it is worth to try. What about non-calcific tendinopathy? As I said, we have not good clinical evidence in this case, but there are some experimental evidence that are interesting. This is a paper that was published by Leonardo, Guiloff, Manuel Brañez, and their group at the Journal of Shoulder and Elbow, the British Journal of Shoulder and Elbow, and they found that those patients that were treated with focus waves before a repair of the rotator cuff developed phenomena of angiogenesis, neoangiogenesis, and lymphangiogenesis. So if the tissue had a moderate degeneration, the tissue react. When the degeneration was severe, there was no reaction. Here we can see a Riley grade 3, there is a moderate degeneration, and there was a very clear response after the use of shockwaves. And this gives us a hope and expectancy in the future to perhaps increase the vascularity of the rotator cuff tendons before surgery. This is another interesting case, not a paper, that Dr. Manuel Brañez from Chile gave me. And this is a patient with an interstitial rupture, partial rupture of the rotator cuff that was treated and was followed by ultrasound, and he was treated with focused shock waves, and they have demonstrated, at least in this case, that there was a healing of the rotator cuff, having an interstitial intramural rupture, partial rupture. So this is another option that perhaps in the future, this is an experimental use, but in the future will give us another way to treat these patients. What about non-unions? And of course, non-unions are treated by doctors with focus waves. Well, you can see here, in this case, it was a patient that was treated with surgery 10 months before with no results, and after 3 sessions of focused shock waves, we got this result and the healing of the non-union. This is a patient 7 months after scaphoid fracture treatment, surgery with no healing, and after 3 months and 3 sessions of shock waves, we got it. So we avoid surgery in this case. This is another interesting case, a patient that had a motorcycle accident 2 years before. He was 2 years earlier operated on with different techniques. To begin was an endomedullary rod, then he got an infection and he was treated with the device that you are seeing in the x-ray. But I received the patient in June with this x-ray. After 3 sessions in September, you can see that the non-union is already healed, and this was in December. So again, we prevent another surgery in this case. This is one very nice case that shows the power of mechanotransduction. A 68 years old lady that was treated, in fact was a case that was referred to me by Dr. Herminio Olivieri, who is in this panel, his foot surgeon. And this patient was operated because annulus rigidus, and there was a failed arthrodesis. I received the patient 18 months after surgery. There is a broken screw, so you can imagine that a revision surgery in this case would be complicated. So this is the way I received the patient, June again. 2 months later, after 3 sessions, we can see that there are some changes. This is 3 months later, and we see that there is a progression in the healing. And finally, 4 months, you can see that the area of non-union has disappeared. This is the follow-up 18 months after shockwaves. So not only we do not only get or got in these cases, in this case, the relief of pain, but also the healing in the x-rays. There are some studies about the efficiency of the use of shock waves in non-unions. And this is a study that was performed in the Austrian system that check and treat all the work-related accidents in Austria. And they analyze different years, and they got that in average, they treat 400,000 fractures per year, of which 10,000 develop non-unions. Of these 10,000, 7,000 can be treated with shock waves, focused shock waves, because there are some indications and some conditions to treat the patient with shock waves, and we will discuss this in one of the webinars that will be related specifically or focused on bone diseases. And the system saves 66 million euros per year just because they use shockwaves instead of going directly to surgery. We are also getting in a new field, working with dentists, trying to apply our knowledge in bone pathology to dental diseases. And we are very excited about this. We have a very strong team of dentists in ONLAT, in our federation, and we are working in that direction. It has been demonstrated that the use of shock waves and radial pressure waves in burns is also very useful. We have an expert, that is Dr. Carsten Knobloch from Germany, that will participate in these webinars in the future. What about neurology or neurological problems? Well, it has also been demonstrated the effectivity of shock waves in reducing muscle spasticity after stroke and in cases of cerebral palsy. So in the future, we will have this indication that it has already developed, more common, more frequently reported, because the results are very good. Myofascial pain syndrome can also be treated, as we said, according to the area of treatment by radial pressure waves or even the combination with focus waves. Here we see a paper by Silvia Ramon, and Silvia Ramon in the picture treating a patient, and the results are very good. This is a very common, very frequent indication, complaint by the patients, and it is useful in many cases. But not all are roses. We have also poor results and complications, as you can see in these pictures. We have just published a paper in the Spanish Journal of Medical Rehabilitation, where we have shown that the complications and poor results should be considered. Generally, we divide these kind of poor results in three possibilities, but sometimes the etiology is combined. Diagnostic error is very frequent and one of the most frequent causes of poor results. And again, I want to stress that we should not treat symptoms. We must treat conditions that are diagnosed, and again, having a device does not transform us in expert in different pathologies. Another option is the technical failure, to use a protocol that is not good or to use a device that is not of good quality. And finally, there are complications, that there are situations that are not expected, that they just appear, and that we must treat. For instance, a patient who faint during treatment, or a frozen shoulder, or a sharp pain that develop after treatment. Well, this is a general approach. I want to thank again the possibility to participate. You can see on the right side the next webinar that will be organized on June 9th. And we can be in touch, July 19th, sorry, it was my mistake, July 19th. And we can be in touch by mail, and we are open to all your questions and all the information that you need. Thank you very much.
Thank you very much, Professor Moya, for this extraordinary conference that can teach everybody how to use this very impressive technology. But not all things are so good as we think. As you have shown, there are some problems in the method, and also there are some contraindications. And for telling us what are the contraindications, we have in our panel Professor José Eid. He is a very good friend from Brazil. He's the founder of the Brazilian Society of Shockwaves Nowadays, he's the General Secretary of the World Society of Shockwaves, and a pioneer in all America also of this technology. Please, Dr. Eid, teach us what are the contraindications that we have in this impressive method.
Thank you, Leonardo, for your kind presentation, introduction. Are you listening well?
Perfect, perfect. Thank you.
Thank you. Thank you. I want to thank you also, the organizer, for this invitation, and it's a great pleasure for me to participate with this great team. I will talk about the basic application techniques and the contraindications about shockwave treatment. I have nothing to declare, and when we think about shockwave treatment in orthopedic and musculoskeletal disease.
Sorry, Jose. Sorry.
Yes.
Can you put full screen, because we are seeing your slide? It will be better. Thank you.
Sorry. Now it's okay?
Now it's okay.
Perfect.
Our first thoughts about the basic application, we must know which tissue will be treated: tendon, muscle, bone, or skin. Which kind of shockwave of generator will be used? Focus or a small or big machine. Normally, big machines needs anesthesia and treatment at the hospital. Or if you use a very small technology or a pressure radio waves. And always we need to look for the evidence related in literature and studies. Daniel already told us about the consensus statement of our society, International Society, and Ibero-American Federation, telling us about this consensus. And this has the aim to prevent improper treatment, always based with the best scientific proof for focus, shockwave treatment, ESTT, and radio pressure waves. And the importance of to have the correct diagnostic, local diagnostic and differential diagnostic, always based with physicians that are qualified to do the shockwave treatment. As Daniel said before my presentation, if you have a device, you are not able to do it if you don't have some specific situations, if you are not qualified. So about the indications, Daniel already told us, and these recommendations also from Naples and in San Sebastian about the definition of focus shockwave and radio pressure waves are different technologies and different indications. And we have also this consensus, and I emphasize here the necessity of trained physicians and a previous diagnostics and a prescription for other no physicians, health professionals. But we have prerequisites to perform ESTT. The aim is to promote ESTT science and good clinical practice. So we need a local diagnostic and a differential diagnostic. It's a clinical examination and at least a simple X-ray. So when we look for local diagnostics after a clinical examination, we need to know which stage this pathology is presenting. Sometimes you have a rupture, as you can see here, of the plantar fasciitis, and you don't have indication for treatment. And the diagnostics differential is also important. Clinical examination is, as we all know, it's very important in the medical field, and for ability to do the shockwave treatment, we need to have also this clinical examination. You can see an example here that a patient has clinical examination of rotator cuff tendinopathy. But if we look the clavicula in the distal third, you can see some reaction and osteology. And when we have the MRI, you can see And after the biopsy, this was a lymphoma no Hodgkin of T cells. So we need to take care to avoid complications doing the wrong treatment. So this is nothing to do with shockwave treatment for sure. What's the position of the patient when we do treatment of shockwave? It depends of the indication, but sitting or lying, and preferable lying position, because sometimes the patient can have a pain and a lipotemia or a low blood pressure, and then this means that you must take care, and I prefer to do in the lying situation. Also about the coupling or the therapy head that you can see here, this is a big focus device doing treatment at the hospital with high energy. So we need to put the therapy head in contact with the skin to avoid bubbles, air bubbles, and we can avoid less energy. And remember that Professor Uski told us that we need to put in contact the therapy head and the skin, and we cannot forget the gel. We need to applicate the gel between the skin and the therapy head. When we try to treat localize the area treated, we can use a CT scan or X-ray. It depends of soft or bone tissue. And sometimes also the feedback patient where it hurts. You can see here ultrasound, for instance, for calcifying tendinopathy. And you can use both isocentric arm, as you can see in the arrow in the middle picture, or inline system, another kind of electrohydraulic generator. Here, example for bone tissue. When you treat bone tissue, you must look for the shortest way. You have the F1, where is the generator, F2, the area of non-union, where you treat the non-union. And this is an example of a patient, a young patient, after 2 surgeries. And with bone graft, we did 2 sessions, and you can see in the right picture that was completely healed, the non-union. And we can use the crosshair, as you can see here in this picture, focalizing the shock wave inside the non-union. About anesthesia, we know that evidence shows lesser efficacy when you use local anesthesia for tendon. So this is not recommended, but there are exceptions. If we do a calcification, tendinopathy, sometimes, not always, but sometimes, depending on the device of energy and patient tolerance, you should do it. And for sure, when you use big bones with big volume of energy, you need to use regional or general anesthesia. The direction of the impulses is important. You should go directly, target the pathology, direct to the point, and you need to avoid lung tissue, big vessels, and nerves within the focus. You see this picture with Daniel, he showed us a complication, as you can see here, and the direction of the impulses. You can use the ultrasound before to avoid big vessels. You see the yellow arrow here. We did previous ultrasound, and we localize the big vessels. And after this, we use the X-ray, and you see here the crosshair showing that we are in the femoral head. This is a case of bilateral avascular necrosis of femoral head. When we go to the contraindications, it's very interesting because when you go to common research advertisement in Google, Yahoo, or even DuckDuckGo, you can see that the first page, for instance, in the first page, fortunately, the first page you find PubMed, ISMST, or FDA websites telling us about the contraindications. But we know that there are some sites that are classified as a reference shockwave educational websites, but they are not. And they bring a lot of confusion and misunderstanding. They say, for instance, that there are absolute contraindications in the brain or for some open wounds. And we could see with Danielle's presentation telling us that in open wounds, diabetic or non-diabetic ulcers, for instance, we have standard indication for these treatments. And they say here, for example, that shockwave damage tissue and local circulation. So these are wrong information and brings a lot of confusion. Also, they classify as relative contraindications in genital area. We know that for dysfunction, erectile dysfunction, there is a relative indication sometimes and others pathologies. When you look for some in the second or third page in a Google or Yahoo or another kind of research, sometimes you find a national health public system. They don't look for the contraindication, but they say to us about patient information or consentment, telling us that anticoagulant medication should be avoided and the patient cannot do the treatment. Even if you go to FDA studies, they say that there are no they don't know any contraindications for ESWT with the device, for instance, for lateral epicondylitis. Or they say that there is no information about contraindication for plantar fasciitis. And sometimes you have some websites that they speak the truth. So for instance, here, we know that when we talk about the approved shockwave for FDA, we know that there are specific conditions for soft tissues and a specific device. So this is very important for us to know about this. Unfortunately, FDA does not differentiate between radial pressure wave and focal shockwave. And fortunately, the ISMST, you can see that many websites, they are introducing our consensus and our information. So what ONLAT and ISMST says about contraindications? The recommendations, indications that these contraindications is always based in scientific evidence and the consensus statement, because we know that we have different technologies, different penetration deep, etc. So we have two big groups of contraindication, the radial pressure waves and focus device with low energy. And the second group is high energy focused. So the radial and focus low energy device is contraindicated in patients with malignant tumor in the treatment area, not as underlying disease, and fetus in the treatment area. These are the two topics of contraindication that we recommend. Also, contraindications for high energy focused is in the lung tissue in the treatment area, malignant tumor in the treatment area, epiphyseal plate open in the treatment area for sure, brain or spine, and severe coagulopathy, and fetus in the treatment area. Beatation that is only severe coagulopathy, sorry. But this is very important. What is written in the device, in the device, manual device? They write that physicians and other healthcare professionals should know the correct indications, contraindications, and adverse effects. They know that we, as a physicians, we need to have knowledge about the device that we are using, current with international guidelines and recommendations. And we need to have information about the number of shock waves, intensity, and adverse effects. They also say that we need to be updated with the medical literature. And in some cases, depending on the generator, patients with pacemakers must be carefully treated according to medical literature. So what's the legal recommendation? There are responsibility of the industry in writing the manual device. there is a big responsibility of us, of the users, the physicians, to read and understand the manual of the device. We need to up-to-date knowledge regarding the indications and contraindications based on scientific evidence for medical societies that have doctors and physicists who are experts in this medical field of shockwave treatment. And indications and contraindications currently are in a dynamic situation with change always based in scientific evidence. So the physician must be updated with the aim to prevent improper treatment and its own consequence to the health professional. So what's the message? I want to show you the message is the education. Education is the answer. Isolated courses and workshops promoted by industry without scientific international society support does not have the current concepts regarding scientific evidence and does not protect the physician and others healthy professional of mistakes, misunderstanding, and medical errors. Our society, both the International Society and the Ibero-American Federation, clarifies the correct indications and stimulate the use of this recommendation to avoid misunderstanding. Even with the health private and public system, it's necessary to explain and to share these recommendations, the indications, and our statements. So I finalize telling you that we have on November in Madrid the certification course to the health professionals. So you can save this date, please. And also you can have in Vienna, in Austria. Hopefully we hope that due to the pandemic situation, but we hope that we presential this Congress with training course for physicians and non-physicians. So thank you for listening and for your patience.
Thank you very much. Thank you very much, Dr. Eid, for this very interesting conference too. I think that with all that you have heard now, you can make questions in the chat. And even we don't have received too much questions, I will put to the panel the first question that in part has been answered by the conferencist. The first question that has been done is, what happened when you pass through a nerve, when you are treating a non-union, for example? This question is done by a Argentinian doctor that is now living in Chile, that has been doing with me a non-union last days, and he asked me during the procedure, what happened with the nerves? And I have some answers here in the chat, but I want to hear Christina Schuh and Achim Loske first. What happened? What do you think in the physics point of view and in the biological point of view? Achim first and then Christina, if you want. So to hear both points of view. What happened, Achim, with the nerve? You don't have, Achim, you don't have the
microphone.
Microphone, please. Christina, also the microphone.
Now
Christina,
you can
the
hear
microphone.
Me. Okay.
Yes, you can.
Otherwise, you have to read my lips, but that's more complicated. Well, from the physics point of view, I could imagine, but obviously it depends on each case, that the part of the nerves could be even destroyed because when the shockwave passes from soft tissue to bone, which is a completely different acoustic impedance, there are going to be very strong reflections and very strong tensions that easily could severely damage nerves. Obviously, it depends on the angle, on the energy, on several factors, but it is something that has to be taken very seriously, and even decide if the object of the treatment is to partially destroy the nerve or not, and then decide the energy and how to treat this area in regard to what the goal is. But I would not wonder if a shockwave arriving or an interface between soft tissue and bone could easily destroy nerves. It also depends if the nerve is outside the bone or inside the bone. So it is not just one easy answer, but it is something that is very, very important and should be considered.
Christina, you have done some, yes, you have done studies about nerves and about shockwaves. Can you tell us biologically what happened, what Achim said, tell us recently?
I think, as with a lot of things in shockwave therapy, it depends highly on the dose and on the pulses applied. So there was a study done in our institute by Thomas Hausner and Antal Nugradi, that because they wanted to use shockwave treatment for nerve regeneration, and they wanted to figure out what is the dose that they can apply to nerves without damaging them. So part of the study was, of course, also damaging the nerve, figuring out what is the limit dose, the limit amount of pulses that you can apply. And they found that, yeah, you can strongly damage nerves with shockwave, but you can also find dosages and amount of pulses that do not damage the nerves. So it depends highly on the dose and the pulses applied, because my research was focusing on Schwann cells that are important for nerve regeneration. And if you have a non-union bone, of course, you also have nerve damage. And with the right dose, with the right pulses, you can also maybe help nerve regeneration. But of course, I think with the dosages applied to non-union bone fractures, it's more on the damaging side.
Okay.
Yes, I believe that is a very important point, the dose, and we have to also define what we mean by dose, if it is the number of shock waves, the energy, the pressure profile. But it is true that at a low dose, you can regenerate cells, nerves, tissue. And so I think that is the crucial word in this to answer this question.
To continue in the same way, I have my personal question. We are talking about low dose, high dose, or middle dose. That is a polemic point that have produced a lot of problems to all of us that are doing shockwaves during our lives. And I would like to know by Achim, that is an expert in this, and of all the panel, what they do consider high dose, low dose, or middle dose?
Yes, I have a slide here. Let me show it to you. Just give me a few.
While Achim is looking for the slide, I would like to say about the topic we were discussing before, that there is also a classical paper by Professor Wang in which he applied focus waves in dogs to the femoral nerves and vessels, and he also demonstrated really severe damage using focus shock waves in that area. And Paul Terán, who from Ecuador, who is here with us, have published reports of patients treated because of medial epicondylopathy with ulnar damage. So we must really be aware of that.
Okay.
I'm not sure if you can see the slide now.
Yes, yes.
Now yes.
So in general, this is what is considered to be the energy density range for ESWL and ESWT. Normally, low dose is under 0.5 millijoules per square millimeter, and what we call high dose, high energy, high flux and density is above 5.5 millijoules per square millimeter. However, this is, well, it is based on experience. There's no physical law or something very precise to say it is exactly 0.5. If you ask me why not 0.4 or 0.6, I couldn't answer. It is just because of the experience from many years. But these are the numbers that are being used nowadays to call low energy flux density and high energy flux density for ESWT.
So there is not a consensus.
Partially answers maybe the question, but since we don't have more information or precise information on this, this is a difficult point to answer, and it is based more on experience than on physical evidence.
There's not a consensus then, Achim, until now.
But
I think it depends on the machine.
International consensus, there is no international consensus. That is true.
What happened, Christina, with the biological aspect of these energies? Do you think that these physics are acting through the tissues in different ways, in the different energies?
Of course, because with higher energies and with higher energies in the laboratory, because in the laboratory we don't have a protective matrix around the cells. Higher energies already include for us higher than 0.2. That's for us in the laboratory, because we're working with cells that are isolated, it's already very high. And I know in the clinics this is very low. So depends a bit on on the application. If you're working on soft tissue, if you're working on hard tissue, they would always to determine how the cells will react, because the cells in hard tissue are used to within a matrix that protects them, and the cells in soft tissue have a different matrix protecting them. So that's always a bit difficult. But what I want to say. I think it depends on the application.
It depends on the application. Thank you very much. Is Dr. Eid want to do a question? But after you do, excuse me, before you do it, I must tell that the consensus in this point, that is the low, high, and middle energy, has not been done until today. So people that is starting this must have the only an idea of what we are telling you in this moment, because we need more and more consensus in between the physics, that there is a group studying it in these federations that could say in the future this relationship between physics and biology. So people that is starting this must consider the high energy as less as it could be possible. For example, there are some papers that is not in consensus, but say about 0.28 millijoules millimeters as middle energy, and from now and over this as high energy. So it's better to be very responsible when you use the devices and not go to the highest level, even in clinic, because we don't have, we are not completely sure until now in what the energy is the best. That is my personal recommendations, because you've been using this more than 20 years. But José Eid of the panel want to make a question. Please, José, what is your question for the rest of the participants?
Yeah, my question is to Professor Loske. Loske, you told us, and we know that the measure of devices, radio pressure devices, is in bar, right? And when we go to focus device, the measure is millijoules per millimeter square. But I see sometimes the industry with some devices, the radio devices, they compare and they put together with the bar the amount of bar, they put also the amount of millijoules per millimeter square. So this is correct. Another question together with this is that you have the generator with pneumatic generator and electromagnetic. They are different when they deliver the energy in bar. Your sound, no sound.
This is
the microphone.
A very good question, and it is a confusion, and I think the companies should be more careful on what they publish in this regard, because normally if you have a pneumatic device, on one side you are adjusting the pressure, the air pressure, which accelerates the projectile. So if you increase the pressure of the compressor that accelerates the projectile inside your device, the pressure that is going to, the radial pressure wave that is going to be generated will be higher. Normally, the pressure of the air, the pressure of the compressor device that accelerates the projectile is given in bar, and the pressure profile that is generated by the device, by the hitting of the projectile to the transducer, generates a pressure profile, and that pressure profile is measured in megapascal. Now, you can generate exactly the same or similar pressure profiles using pneumatic or electromagnetic projectile acceleration inside your device, and the outcome, the pressure profile, could be very similar or not, but it is very, I would even say, dangerous, and it is critical to just compare bars adjusted on the device and the outcome of the pressure profile. Because if you compare two different devices, let's say that both of them are pneumatic, and on one of them, let's say any manufacturer, doesn't matter, you adjust 3 or 4 or 5 ATM and bars, and the outcome can be very different from one model to the other because it is designed different. So if you want to compare a study or a protocol and reproduce the same protocol on a similar case, on a similar clinical case of a patient that was treated in some part of the world with another one, then you have to be very, very careful. You only can compare and apply, or should compare and apply, the same protocol if you are using exactly the same, not only manufacturer, but exactly the same model. And then you can say, okay, I adjusted 5 bars, and I know that the outcome, the output, the pressure profile of this device, because it is exactly the same device that was used in another hospital, is the same. But only in that case, if you have two different pneumatic devices, different models, or even different manufacturers, then it is very dangerous just to, or critical, you cannot compare the treatments if you adjust 5 bars on the pressure of the incoming air and on one device or the other. So I think the best should be to talk about the outcome, the output of the device, and not on what you're adjusting. And this is a responsibility of the manufacturers. I think they have, they should give more information on that, and
to be aware
as a user of these devices. And it is so it is a very good and important question that you made.
Thank you.
We don't have many questions in the chat, but there are some questions that we can do between us that are concern about the different problems of shockwaves. And I have one question to the clinicians, as Daniel and Jose. We have pressure shockwaves, right? Pressure shockwaves and shockwaves, radial pressure waves, excuse me, and shockwaves. And there are different groups in medicine that are not doctors that are using this type of energies. I would like to know by Jose and by Daniel, why, for example, physiotherapists that are a group of people that are doing paramedic help to the doctors cannot use the real shockwaves and then can use the pressure shockwaves. I would like to know in the clinic, in a clinical point of view, why you have to do that difference. And I would like Jose to tell me what is his point of view as General Secretary of the World Association.
Well, this is a big fight with physiotherapists because they want to, in some places, they want to do everything, unfortunately. We know that we need the correct diagnostic to do a treatment. We cannot do a treatment with a simple point of pain in the shoulder, at the shoulder. We need to know what's happening. And this, I remember here in Brazil, maybe 10 years ago, a publication in, I don't remember, the British Medical Journal, Daniel, maybe it was this. They compare shockwave treatment with subacromial pain. So it's a big confusion, even with some publications. Subacromial pain, you have a lot of problems. You can have a calcification or a rupture or whatever. So you need to have the diagnostic, the correct diagnostic, before indicate the treatment. So this can only be done by the physician. The physician, and sometimes not the general physician. We know that we need a specialized, a shoulder surgeon, right? Or a foot surgeon to do the correct diagnostic. So the diagnostic is very important for the treatment. We know that focus is a superior technology. We know that radio devices was created at the end of around 1999. And when we talk about marketing, the companies try to compare shockwave with radio waves. And we know that this is only for selling. I use both technologies. I like the radio pressure wave and I like focus shockwave, but we need to know when to use. And the physiotherapists, at least here in Brazil, they are creating a very big confusion because they want to do everything and they are not responsible sometimes for the treatment. So they need to have ISMST, as you saw in the slides here. We recommend that the non-physician health professional, a nurse or a technician or a physiotherapist, should do the treatment only with radio pressure wave under a diagnostic and a prescription before done by a physician. So this is the good situation. But we need to remember that if the MDR, medical device regulation, if we have a classification of the focus shockwave as a device that can bring dangers to the patient, will be classified in a way that only physicians can do it. And then will be done. But unfortunately, these mistakes and misunderstanding brings legal and fighting in the law. to do the treatment with some physiotherapist that does not know. We have seen in the last years a big amount of absurds coming from people that are not trained, they don't know the treatment, and this is only a commercial point of view of industry, or some of them, trying to mix both technologies. That's the reason why ISMST and OnLat also, and others, national societies that are together with us, try to show the correct way of this treatment. I hope to answer you.
Thank you very much. I agree absolutely with you. And I don't know if Daniel also have to tell something about this, because we're short on time. So we have only a couple of minutes, please, Daniel, and we have to finish the...
No, as I said in the conference, there is a different level of risk with the devices, and this is proved from the physical point of view, from the biological point of view. So I think that that's the most important consideration. There is a different level of risk, and when a device is used for different indications, at least for the control agencies, the higher the indication with a higher level of risk is the one who gives the level of risk of that specific device. So we must consider that. That's the point. No, nothing more than that. We will go in deep with the different indications and the different pathologies during this year. So just on my side, to thank OrthoTV, to thank all of the panelists. We also have very good friends that have joined us, like
we have
Dr.
some
Karim.
problems, Daniel. Well,
can you hear me?
Yes.
Yes.
Okay. Just to thank Dr. Karim Freitag from Spain, and Dr. Arminio Olivieri, and all the friends that have joined us. So I don't know if you can hear me, Leonardo, but it seems that you have problem with your web. Well, so thank you very much. I will close this webinar, and we will keep in touch.
Thank you very much.
Thank you.
Thank you.
Bye-bye.
Thank you.
Bye.
See you
Bye.
soon.
Bye.
Bye-bye. Thank you.